patient is an 83-year-old patient of mine. She's a diabetic, and she has long-standing valvular heart disease. You'll see immediately which heart disease she has. Her daughter is a nurse, and she takes care very much of her. And she was somehow always in very good shape. She takes care of herself. Her husband has died, but she is alone in her house and lives with her daughter, helping her at times. But I will show you the first study that I have from her, which was performed in February of 2011, so 1.5 years ago. And to make things short, she has aortic stenosis. Remember, we said that most of our cases today will be dealing with the aortic valve. Now, see good left ventricular function. I'll just increase the gain here. We have aortic valve sclerosis, okay, or thickening of the aortic valve and calcification, rather. And here's the gradient. This was the gradient 1.5 years ago. How would you grade aortic stenosis? Maybe you can think for yourself how you would grade it to give you some help. Maximal velocity or maximal gradient is 42 millimeters mercury. The mean gradient is 30 millimeters of mercury. One thing is clear: normal ventricular function, gradients below 40 millimeters mercury. Therefore, we have maybe moderate aortic stenosis, but certainly not severe aortic stenosis. And she was followed up the next year. This is now in February of 2012. Look at her images. Not much has happened with respect to left ventricular function. She still has good left ventricular function. Now this is the two-chamber view. Okay. This is the four-chamber view. And here we have the gradient. How much is it now? Okay, so now we have 4.6 meters, which adds up to a maximal gradient of 85 and mean of 54, which basically means we have a progression within 1 year. It's now certainly severe. And obviously, we'll ask the question if she's symptomatic or not, if she would operate her or not. And she was not symptomatic. She was doing fine. And, in an 82-year-old, you're not very happy to, put her to aortic valve replacement anyway. So you're always happy when they come and say they're doing fine. So in this case, we said, okay, we'll check her and let's see what happens. And I did not hear anything from her. And then a few days ago, her daughter called me up and said, she's really doing bad. She has no, she's in her bed, and she can't move around, and she has a shortness of breath, and we have to do something. And so I brought her to the hospital, and this is the echocardiogram that I now took only a few days ago. This is again the aortic valve. Just looking at the morphology, you will probably not recognize that much has happened. There's still aortic stenosis, but what is pretty apparent is that now she has poor left ventricular function. Okay, so left ventricular function is significantly reduced. Let's see if I can find the best image. Here, this is left ventricular function. You can clearly see that the ventricle is now much larger than it was previously. It seems as if the left atrium is larger than before. This is her two-chamber view. Okay, look at the two-chamber view, and now the apical long axis view. Poor left ventricular function. And how do you think the gradients are? Well, lower. Surprising? Not really. It's obvious that now she has less flow across the aortic valve because her left ventricular function is now deteriorated, and therefore we have a situation which we could actually call low flow, low gradient aortic stenosis, but a situation where we are quite certain that it is true low flow, low gradient aortic stenosis. Why? Because we have previous exams that showed us that she has a very high gradient if function is normal. So, and the gradient would certainly not decrease just because itself. It has to be some hemodynamic reason behind the deterioration. So basically, she's now decompensated with her left ventricular function, and she is symptomatic. So The question is now aortic valve replacement or maybe percutaneous aortic valve replacement, but something has to be done. That was our clear judgment of the case. But this is not the question I would like to ask you. I would like to ask you a different question, which will come up in a second. What would you expect to find on the angiogram? We need to perform an angiogram simply because if we want to evaluate her for TAVI or aortic valve, surgical aortic valve replacement, we want to know what the coronaries are like. And I want you to take a look at the different options you have. Single vessel disease, do you think it's an LAD stenosis or occlusion? Do you think the patient has single vessel disease, RCA problem, or maybe she has normal coronaries, or does she have severe multi-vessel disease? The risk factors, I can give you those too. She's diabetic but not taking insulin. She has mildly elevated blood pressure values, and she does not smoke. She has never smoked. Most of you think she has multi-vessel disease. Well, basically, if I just go from the patient, she's old, very often you have multi-vessel disease. And I agree, this is probably the most likely option. But the reason I'm asking you the question is because I wanted to see if you catch the regional wall motion abnormality, which is also present in this patient. Here is the two-chamber view. Now, look at the inferior wall. This is not only hypokinetic, but it is simply akinetic. It's not moving. Look, here, there is no wall motion at all here, okay? So this is very suspicious of an RCA problem. To prove that this is true, I'll go back to the coronary angiography. Here is the left coronary angiogram. We have fairly nice vessels of the left coronary artery. There are just minor abnormalities, but there is no stenosis. Now let's go to the right coronary artery. Okay, and what we find is we find a terrible right coronary artery. If you look closely, you see that there is an ostial stenosis, which is almost subtotal. She has almost completely occluded right coronary artery. And then we have a lot of different abnormalities of the coronary arteries as we go down towards the middle. And it's also a very large right coronary artery. So to put things together, I think that this patient basically had a combination of two problems. The first problem was that she has severe aortic stenosis, which is a burden to the left ventricle in the first place. And then she also has ischemia, or maybe even a small infarct of the right coronary artery. And that kind of brought the boat to tilt and led to complete cardiac decompensation. Now we're evaluating her, and I don't know what we're going to do, but I think it probably will turn out to be aortic valve operation with bypass surgery, because she's fairly in a good clinical shape and she's ready to go. She wants to have this done, and she says if it has to be done, it just has to be done.